Thank you very much and good evening, everyone. I'd like to show an innovative application of the ping-pong technique that was performed at our center. So this patient was a 50-year-old gentleman with low BMI. That is relevant later on in the case. He was hypertensive, dyslipidemic, and diabetic, which is also relevant later on in the case, and presented with CCS class 3 to 4 angina for 3 months on optimum GDMT. ECG had a few T inversions on the anterior leads, and he had a preserved ejection fraction. This is his coronary angiography. As you can see, there's a complex CTO of the LAD with a JCTO score of approximately 2 and Rentrop grade 3 collaterals from the non-dominant disease-free RCA. So we have here a CTO of the LAD with collaterals extending from a non-dominant RCA. When we look at the left circumflex system, we had a dominant circ with discrete 90% stenosis proximally, followed by what looks like a true bifurcation lesion at the level of the principal OM, that is Medina 011, and there was additionally another 80% discrete stenosis in the LPDA. So we have here a CT of an LAD as well as a dominant circ with multiple lesions. The syntax score was approximately 32. We adopted a heart team approach, but the patient, given that he was 50 years old, refused to undergo CABG, and so we had 2 complex lesions to tackle. We decided to go for the C2 LAD first. If that would open up, then we would tackle the whole dominant circumflex, including the complex non-left main bifurcation lesion. We generally go for bi-radial approach for CTOs in our center with dual injection, and given that this patient had very small radial arteries, we are also quite accustomed to performing slender CTOs with 5 French guides, which small radials would accommodate. So we decided to adopt this slender CTO, and here we did another interesting thing. We took 2 5 French JL guides, one for the left as well as the right, because we know that the RCA can be engaged with the JL, and we only needed the JL for dual injection, and at which point we needed to engage the RCA. So once we had a clearer picture, we proceeded for a CTO wiring with a Fielder XT guide wire, guided once again by dual injection. And the problem with slender approach is support. So in order to enhance active support, there was alpha looping, as you can see in the middle panel, and the LAD was then crossed by antegrade wire escalation, aided by dual injection. We took an IVAS catheter down and sized it, stented the distal LAD, then stented the proximal to mid-LAD with a 2.5 38 millimeter drug-eluting stent with a satisfactory angiographic result. So now that we had the LAD, we decided to go for the left circumflex also. And here it's the twist, really. We have 2 5 French JL guide cats for the CTO LAD intervention, and we have bi-radial access. So because a bifurcation lesion would ordinarily require 6 French, and this patient had very narrow radials. It was about 1.9 and 1.89 bilateral radials on ultrasonography. So we thought then why not to use the 2 5 French JL guides that are already in situ and handle this complex bifurcation lesion in case there was a necessity for a 2-stent strategy. And this is where we use the innovative aspect of a ping-pong in an elective setting. Usually this has been described in emergency settings, but we use it electively here. And this is really the key slide. So keeping an anchoring wire in the LAD, we wired the OM first through the JL guide that was previously present within the left main, through which we had already revascularized the CT of the LAD. And then what happened was we removed the left main guide outside. It was slightly displaced, and the second JL that was previously used for RCA engagement was then used to engage the left main, and we wired the LPDA, that is the circumflex, through the other bifurcation aspect of the bifurcation through that. So this is essentially what the ping-pong technique entails. And after aggressive predilatation of the bifurcation lesion, we did an IVAS interrogation, stented the LPDA with a 2.5 18 millimeter drug-eluting stent. And now coming to the bifurcation, we have here an acute angle, not really any discrepancy between the diameter of the main branch and the side branch. And although it's not a 1-1-1, we decided to stent main branch distal to proximal main branch by using that first lesion in the proximal circumflex also as part of the bifurcation. And this is where we also again use the ping-pong technique, where one wire is engaged through one guide, another wire is deployed through the other guide, and the stent was used through one of the guides across into the proximal to distal main branch. This was followed then by the first pot. Then, as you can see in the third panel, there is a distal pullback and rewiring through the distal stent strut. At no point are both the guides engaged. Only one can be engaged at a single point, which is essentially what a ping-pong technique entails. We then did a first kiss followed by the side branch stent with a 2.5 33 millimeter drug-eluting stent, Followed this with a rewiring. Second case, each of the balloons was sent through each separate JL guide catheter here, and then followed that with a final pot, and this is the satisfactory angiographic result. So in conclusion, we know that transradial is feasible for all sorts of complex PCI, and slender PCI, which is essentially downsizing the guide cath, is sometimes required, especially among diabetic patients with narrow radials, and we see a lot of them at our center. But a 5 French, we all know, cannot handle a complex bifurcation lesion with a 2-stent strategy. And this is where slender ping-pong can solve the problem. But this is not to advocate that everybody should have bi-radial access in such a case. We adopted this because we already had bi-radial access present for the dual injection of the CTO of the LAD. So this is not advocated for routine use, but in such exceptional cases. And there are advantages in case of bifurcation lesion. For example, you can avoid wire wrap. There's accommodation and easy delivery of multiple hardware because it's a virtual 10 French system when you think about it. And there is no necessity for changing multiple guides, thus reducing radial artery spasm also. And of course, the ability to adopt any of the 3 main upfront 2-stent strategies. With that, I'll stop. I'd like to acknowledge my mentor, Professor Said Rahman Khan, who was the primary operator of this case, and thank you for your attention.